In Chapter 13, we will be discussing recognizing different sports injuries. So, no matter how much time is spent on injury prevention, eventually injuries will occur. It's just the nature of being active and/or playing sports. So, injuries can be either acute or chronic in nature. Acute injuries are a result of trauma. So it's something that just happened, say for instance. We know specifically what caused it usually. Things that are acute injuries would be fractures, sprains, strains, contusions, and possibly nerve injuries. Chronic injuries are caused by repetitive and/or overuse activities. So a lot of times if you ask somebody when they got hurt, they won't necessarily know. They'll say, oh, it started hurting around this time, but I don't remember a specific event that caused it, or there wasn't one jump that caused it. But over time, it seems like jumping started to hurt, or running started to hurt, or throwing started to hurt. So it's usually not one specific incident. As far as diagnosis of injuries, this can only be done by a doctor, a physical therapist, or an athletic trainer. A personal trainer or coach or EMT can't diagnose an injury. They can just say what they think the nature of the problem is. The first type of tissue that we're going to go over as far as tissues that can be injured is bone. The structure of bone partially depends on what kind of bone we're talking about. But when we're talking about a long bone, say for instance in this photograph on the slide, this is the tibia. For a tibia, a long bone like a tibia or the humerus or a femur, we're going to have a diaphysis, which is the shaft of the bone, so that middle part of the bone. It is hollow and cylindrical and covered in compact bone. So it's fairly hard. It's also the thinner part of the bone, so this part can be easily damaged because it's just not as thick as the other parts. Another part of a long bone is going to be the epiphysis. So this is going to be the ends of the long bone on either side. This is composed of porous bone, so it's a little bit more spongy or less dense than the shaft. And it has a cartilage covering, so a shiny, hard covering. This is also where we get growth. The epiphysis is where we get growth in the bone. The cartilage that we have covering the joint surfaces at either end of the long bones is a kind of cartilage called hyaline cartilage that is smooth and hard, and you can kind of think of it as if we're looking at a chicken bone that you've detached from the chicken, and we're looking at the end of the chicken bone, that's kind of slick, hard substance at the end of the bone is the same kind of cartilage. As far as the covering of the bone, this is known as the periosteum. So peri or perimeter, the perimeter of the bone. So osteo is bone. That refers to bone. So the periosteum, or the covering of the bone, is a dense fibrous covering. The periosteum contains blood vessels and osteoblasts. So the osteoblasts are cells that make new bone cells. Some other characteristics of the bone. A bone is a dense connective tissue matrix, so it's a very hard substance. There's an outer compact tissue, so the covering of the bone is very hard, and then the inside is a porous cancellous bone, so a little bit more spongy. In the periosteum, we have osteoblasts that are helping to make new bone cells, and there are also inside the bone osteoclasts, which clear out old bone cells. So there's a constant balance between the osteoblasts making new bone cells and the osteoclasts clearing out old bone cells. And the ideal situation is to have a balance between those where it's equal, although it is not always equal in every part of the bone. And if the osteoclasts are clearing out old bone cells faster than the osteoblasts are making them, then sometimes we can have a weakness in the bone. Another, I think, important concept for people to understand is when we talk about a bone being damaged or disrupted, we call it a fracture. A fracture means the same thing as a bone break. A lot of people will say, oh, I didn't fracture my bone, I only broke it. Well, they're the same thing. So we can have small fractures, we can have large fractures. There are many types of fractures actually, but all of them are the same thing as saying that you broke your bone. So on this slide, we have 6 types of acute fracture. Fractures are caused by a result of an extreme stress on the bone. And there are multiple different types of stresses that we can have on the bone that will dictate the amount and the type of damage that occurs in the bone. Fracture is considered a serious injury. And with fractures, we can have either a partial or complete disruption of the bone. So if we look at these pictures on the slide, look at the comminuted fracture, that is basically a complete disruption of the bone. Whereas if we look at the linear fracture, the entire bone is not disrupted. So there is a part of it that is. Fractures can be closed, which means contained within the skin, or open, which means that the fractured part of the bone has come through the skin. I've been pretty lucky. I have yet to see an open fracture in my career, as one of the only things that kind of icks me out as far as injuries goes. And I don't know why. Blood doesn't bother me. Fractures don't bother me. But for some reason, the bone sticking out of the skin makes me a little bit queasy. So most often fractures are closed fractures. If there is an open fracture, then we also need to be concerned about infection and other more serious things than just the fracture. As far as fractures go, it's going to present with a deformity. So most of the time, although not always, a lot of times we can see that the bone doesn't look right. It's maybe bent the wrong way, or the person's going to be very point tender directly over the bone. So it's not going to be tender over the soft tissue, it'll be over the bone. They could have crunching or crepitus and or swelling. My son recently broke his radius in his ulna, and they weren't very large fractures, but he literally just hurt over the bone, and his bone actually hurt pretty much from his wrist to his elbow. He had complained of pain there when he first got hurt. As far as the fractures we're looking at on this slide, the green stick fractures are more of a splintering type of fracture as opposed to the bone actually being a very distinct fracture. And those green stick fractures are more common in kids because their bones are more flexible than adults' bones are. When an adult has a fracture, the bone tends to shatter or splinter in a way that's more of a shattering type of motion versus parts of the bone splintering off. So the green stick fractures are more common in kids. A comminuted fracture, is a fracture where the bone kind of explodes into lots of pieces. A linear fracture is a fracture that follows a parallel line with the bone. Transverse would be at a 90-degree angle across the bone. An oblique fracture is at an angle across the bone, and a spiral fracture occurs when there is a twisting motion, and it will cause what looks like a screw thread or a spiral in the bone. As far as load characteristics that will cause a bone injury or a fracture, bones can be stressed or overloaded by tension or pulling, compression or pushing together, bending, so kind of bending sideways, like you were to try to bend and snap a twig, twisting, and or shearing. So shearing would be like a back and forth motion at a 90-degree angle across the bone. The amount of load can dictate the type of fracture. So usually if you have a higher velocity or a stronger force put through the bone, that's going to cause a more complex fracture. So we tend to see more complex fractures in higher velocity sports with a lot of load like football or rugby or maybe motor vehicle accidents. While most of the force that's going to cause a fracture goes into fracturing that bone, the force is also absorbed by nearby soft tissues, so it is possible to get soft tissue damage to the surrounding area as well. Having said that, most commonly, in my experience, if somebody, say for instance, fractures their ankle, they don't usually sprain it at the same time, although it is possible to do that. Some bones will require more force to fracture than others. Our femur is our strongest bone in our strongest long bone in our body, so that's going to take a lot more force to fracture that femur than it would take to fracture your phalange or one of your finger bones. Those finger bones are quite a bit smaller than your femur. The femur is going to take a lot more force to cause damage. As far as the healing of a fracture, as far as our normal acute fractures, most fractures to heal will require immobilization, most often in a cast, but sometimes people can get away with wearing a splint or a walking boot or something like that. It's going to take about 4 to 8 weeks for the bones of the arms and legs to heal. So this is talking about more the forearm and the lower leg. The femur or the humerus may take longer than that. It also, as far as the bones of the hands and feet, that's going to take about 2 to 6 weeks, most commonly. There are exceptions to those rules, but these are our general recommendations or general guidelines. As far as what happens during fracture healing, basically you have damage to the bone or a fracture, and then the osteoblasts and the periosteum that are close by will lay down new bone and form what we call a bony callus, which is basically like scar tissue in the bone. But from then on, we'll be able to see that there's a bony callus or that there's bony scar tissue. So at some point, it may start to look more like regular bone, but it will pretty much, for quite a while, look slightly differently on x-ray where that fracture had been. If the bone is near the skin, we may even be able to feel that bony callus. As far as following cast removal, the normal stresses and strains placed on the bone throughout the day will aid in the healing process of the bone. Having said that, if somebody has been in a cast for a while, a lot of times they would benefit from doing rehabilitation to help restore the function of the muscles, especially if they're trying to get back to play right away. If I have an athlete who is thinking that they're going to come straight back into playing rugby after having a cast on for 8 weeks, that's probably not going to happen. They're probably not going to be strong enough to keep from getting injured in a different way or re-injured as far as protecting themselves. So I would want to make sure they had at least a week or two to do some rehab as well. Stress fractures are a specific, special kind of fracture. Stress fractures are caused by quote-unquote overuse, and they're considered a chronic fracture, not an acute fracture. So you'll see often in the slides that I present that I kind of do a quote-unquote overuse. I do this because there are some people who can do ultra marathons and ultra triathlons where they're, running like 100 miles or something crazy that don't get overuse injuries. So overuse is a condition that's caused by somebody doing an activity that is more than their body can handle. So basically, they're doing something that their body is not strong enough to handle, or that they're using the improper mechanics that are causing stress on whatever the body part is that they're not strong enough to withstand. So overuse is kind of a relative term because some people can do, run marathons, back-to-back weeks and they're fine, and other people can't even train for half marathon without getting a stress fracture. So overuse is relative to the individual. Now, stress fractures may be caused by a lot of different things. So we could have overload from a muscle contraction on the bone, so the muscle is pulling too hard on the bone. We could have a muscle imbalance that causes more stress on the bone in one spot. We could have changes in training surface or changes in types of shoes. So this is especially common when somebody goes from training on a softer surface to a harder surface. So say, for instance, if somebody's used to running on grass, then all of a sudden they start running on a basketball court, that could be likely to cause a stress fracture because their body's just not adapted to running on that surface yet. The other thing that could cause a stress fracture would be a rhythmic, repetitive stress. So something like running, for longer distances than somebody's used to. So we'll often see stress fractures occurring when somebody has all of a sudden increased their mileage quite a bit with running. Basically, the definition of a stress fracture is that we get this micro trauma that causes a fracture. The periosteum, or the covering of the bone, will become irritated. That's going to stress the underlying bone, and that periosteum will kind of pull on the underlying bone. The osteoblasts within the bone can't keep up with the osteoclasts because of that stress, and a fracture occurs. As far as the signs and symptoms of a stress fracture, it will begin with a dull ache directly over the bone, and then it becomes worse over time. Initially, they'll have pain at a certain point in activity. So oftentimes people will say, I can run for exactly 45 minutes before my leg starts to hurt. And then as the stress fracture gets worse, or as the person continues to play on that stress fracture or run on that stress fracture, the time that they're able to run will get shorter and shorter. And then also they will start to have pain after activity, not just during. Early detection of stress fractures can be difficult because even if we think somebody has a stress fracture and we send them to get an x-ray, the x-ray won't necessarily be super helpful. X-rays are only helpful with stress fractures once the healing begins, because we'll start to see the activity of the healing on the x-ray and that bony callus starting to form. Prior to that, sometimes you don't see that stress fracture on an x-ray. So the individual would need a bone scan as a definitive test to diagnose them with a stress fracture, because the bone scans very specifically show activity within the bone, even if it's prior to healing. If we do suspect a stress fracture, we want to have the individual stop activity for 14 days. So stop stressful activity. If somebody is having pain just with running, they may be able to tolerate swimming or aqua jogging just fine, as long as they're not doing any pounding on the bone. After those 14 days, we want to slowly increase activity. So we're not going to go from only aqua jogging to running 5 miles. They'll have to slowly increase their activity. Even though we say that somebody is going to stop their activity for 14 days or 2 weeks and then start back to activity, it can take up to 6 to 8 months for a stress fracture to heal completely. So even though we tell somebody that we're going to take 2 weeks off, that doesn't mean they're going to be healed by the end of 2 weeks necessarily. Generally speaking, stress fractures do not require casting, just rest from the activity that's causing irritation. Now, if a stress fracture gets bad enough, the person could be put on crutches or immobilized in some way, but it's not very common. The only person I actually know who's really been put on crutches for a stress fracture was my best friend from college, who ran and ran and ran until she had 8 stress fractures in an area about 4 to 6 inches long in her tibia. The best part about that story is that she's also an athletic trainer, so we are not necessarily the best patients as athletic trainers either. If somebody needs rehab to correct the cause of the stress fracture, so if they have a muscle imbalance, or if they have poor muscle contractions, or maybe certain muscles in their leg are stronger than others, or certain muscles are too tight in their leg, then we are going to want to do rehab and address those issues, or the problem is likely to reoccur. We've just talked about bones and injury to bones, and now we will cover joints. A joint is where two or more bones meet. So a specific kind of joint is called a synovial joint. So a synovial joint has two or more bones and has a capsule or ligaments. You can think of a capsule as being almost like a turtleneck that surrounds the two bones at their intersection and helps to keep them together. Ligaments are more distinct. So a ligament might be more like a round or a flat band of tissue that will attach one bone to the other. The joint is also going to have hyaline cartilage on either bone, on either side of the joint. That's that shiny, slick cartilage that we talked about. And there will be a joint cavity with some synovial fluid in there. So the joints have some fluid in to help with padding and shock absorption, so the bones aren't usually specifically touching each other. They're usually padded by synovial fluid and or cartilage to help keep the bones from grinding on each other. We also have mechanoreceptors within a joint. Those are basically specific nerve endings that provide information relative to the joint's position. It's how you can tell that you've partially twisted your ankle before you feel pain, or that your elbow is bent to 90 degrees. Even with your eyes closed, you can kind of guess that, and that's because of those mechanoreceptors within the joint. Some joints have a meniscus, which is a special kind of cartilage for shock absorption and or stability. Sometimes instead of being called a meniscus, it's called a labrum, but they are very similar. Those structures help to provide stability, and they also help with the padding or the shock absorption. And they're a special kind of cartilage called fibrocartilage, so it's not the smooth, shiny cartilage as much as it is a denser, tougher cartilage. So as we already talked about with the distinct ligaments, those are thickened portions of capsule or a separate band of tissue, but they're distinct. We can see or palpate them separately. Those are going to attach bone to bone, and they partially dictate motion. So if we look at this knee joint in the picture on the slide on the bottom, we have the anterior cruciate ligament. You can see right in the middle of the knee. Because of the way that the ligament fibers run, and because of the placement of the ligament, it's going to dictate the motions that the ligament helps to stop. So with the ACL, or the anterior cruciate ligament, it helps to stop forward motion of the tibia on the femur. We can kind of see that based on the fact that it runs from the femur to the tibia. So if the tibia wanted to slide forward, then that would possibly stop that if it was strong enough. The other motion it will help to dictate is rotation, and because it's at an angle and because the fibers run in slightly different directions, it will help to stop rotation and also an opening of the knee to the side, or a valgus motion. So that's a more complex ligament as far as motions it dictates, but it's a good example. As far as injuries to the joint, dislocations and subluxations tend to be more serious. A dislocation of a joint is when at least one bone in a joint is forced completely out of joint. It will need to be put back either by the athlete or participant or by a doctor. It's not going to slide out and then slide back in. So this particular individual in the picture has dislocated his shoulder. A subluxation is a partial dislocation. So if somebody partially dislocates their shoulder, it will feel like it slipped out and then went back in, or they might say it shifted or something like that, but it won't stay out. So if somebody dislocates their shoulder and it stays out and then they move their shoulder and it goes back in, I would personally still consider that a dislocation. Subluxations are more common in the patella and the shoulder than other joints, but they can happen other places as well. As far as signs and symptoms, especially with the dislocation, we're going to have a deformity. So like this particular individual, you can see his shoulder doesn't look normal. And if somebody has a subluxation, the bone has gone back into the joint, so it's not necessarily deformed. But they'll say they felt like a slip or a slide, or that it popped out and popped back in. Sometimes the deformity actually can be kind of hard to see. Say, for instance, if somebody had a posterior shoulder dislocation, that can be a bit difficult to see because it goes backwards and it rests pretty much on the front side of the scapula or shoulder blade. So sometimes you can't really see that very well, especially if somebody's wearing a shirt. So most of the time we like to have people remove their shirt if they've injured their shoulder so we can look at it and see what's going on. And also we want to try to palpate to determine normal contours, and we'll do that bilaterally, so both sides at the same time, so we can try to decide what is normal anatomy for that individual. Some other factors associated with dislocation are if somebody's limb is out of position, then they're going to have a loss of limb function. They're going to have swelling. If it's a dislocation or a subluxation, they will have swelling, and they'll be point tender. Most people are very uncomfortable while their joint is dislocated, but once you put it back in, they feel better. It's just more sore. Some additional concerns that we have about dislocations and subluxations are that when a joint comes out of place, especially for a first-time dislocation, we can get avulsion fractures. So on the way out, say the head of the humerus and the shoulder can knock a piece of bone off of the glenoid fossa where it normally sits, or you can get the bicep tendon tearing off a piece of bone or something along those lines. Another thing that can happen with individuals who are still growing, so mostly kids and teenagers, is you can also get a growth plate separation, because a lot of times it took a lot of force to get that joint out of position, and the growth plates are at the ends of the bone near the joint. So we want to be really careful, especially with a child with a first-time dislocation. I had a coach once get very upset with me at a rugby tournament because a 12-year-old dislocated his shoulder and I refused to put it back in place immediately. And I finally just told him I'm not okay with his arm always being longer or shorter than the other one, because I put his shoulder back in place when he could have a possibility of having a growth plate injury. And immediately he calmed down and said, "Oh, I didn't think about that." So yeah, just because something's out of place, as humans, we want to make things right again. We want them to be put back, but especially if it's a first-time dislocation, we don't do that. It should be done in the emergency room. For repeat dislocations, that's a slightly different story. So another concern is once somebody's dislocated a joint, it's always going to be easier to dislocate. So we tend to say once a dislocation, always a dislocation. That joint will always need extra protection from the muscles around it. They will always need to be stronger on that side, because now the ligaments have stretched out beyond their normal capacity, and it will always move more than it should. So our treatments for a first-time dislocation, we want to rule out, or we want to treat it as a fracture until we know differently. So really we'll have to wait until they get an x-ray in the emergency room. We do not put these back into place yourself. The individual will get an x-ray. They'll be practicing their price. They'll be in a sling for 1 to 2 weeks. And that doesn't mean they're going to be able to return to play at 2 weeks, but if they've only been in the sling for 1 week, then they've done some strengthening, then maybe 2 weeks. But usually return to play is in 2 to 4 weeks for a first-time dislocation. That's going to be a little quicker for a subluxation because there wasn't as much damage usually. So subluxation return to play might be 1 to 2 weeks. If somebody has repeatedly dislocated or subluxed, then usually their soft tissue damage isn't as bad, because they cause most of the soft tissue damage the first time they dislocated. So sometimes they can get back to play faster. The other thing is repeat dislocations may be reduced by the athlete if they're trained to do so by their doctor. As athletic trainers, we're often trained on how to do that. But again, I would never do it on a first-time dislocation, only on a repeat. And I've had people who were very small who I thought, oh, I can for sure get this back in, no problem, not an issue, and I absolutely could not. I think I treated a rugby player once who was about 120 pounds, and I absolutely could not get his shoulder back into place. He was way too tense. It wouldn't relax. So just because somebody has repetitive, and he dislocated 4 times, and he said he had to be sedated every single time. So just because somebody has repetitive dislocations doesn't mean it's going to go back in easily. Another more common type of joint injury is a ligament sprain. Usually these are more minor than a dislocation, but some very bad sprains could be about the same or worse. A ligament sprain is basically damage to a ligament. So we sprain ligaments, we strain muscles and tendons. So SP, sprain, is for ligaments. So a sprain is a damage to a ligament from a traumatic joint twist or overstretch, usually. What happens is you get a stretching and or a tearing of the tissue. So we have a grading system for sprains, and it's based on severity. So if someone has a grade 1 sprain, we consider that a minor sprain. The person will have some pain, minimal loss of function, so they should be able to use that body part relatively normally. If it's a finger, they'll probably still be able to use that hand. If it's their ankle, they'll be able to walk on it, although maybe not run. Or they might be able to jog slowly. They will not have abnormal motion when we do our joint testing, our special tests. The person might have some mild tenderness, and they could have some slight swelling and or joint stiffness, but not necessarily. For a grade 2 ankle sprain, this covers a lot of ground. This is a moderate sprain, and it covers so much ground as far as injuries go that I even tend to do subgrades within the grade 2 or moderate sprain. So I might say a minor grade 2 sprain or a moderate grade 2 sprain or something like that. But for your purposes, for a grade 2 or a moderate sprain, the person's going to have pain, moderate loss of function. So they'll probably be able to walk on it possibly, but they won't want to. They'll be limping on it. They're going to have more moderate swelling. So this is a case where when you look at the ankle, you'll be able to tell very quickly that it's swollen. They'll have some instability, so we can feel abnormal motion when we do our special tests for the ligament. And the person may also say that it feels like that particular joint is giving out on them when they're walking, say for instance. Somebody with a moderate knee sprain might say that it feels like my knee wants to give out on me when I'm walking. If we were to look at a moderate ankle sprain on an MRI, we would see some tearing of the ligament fibers and some joint instability. So there'd be some gapping in the joint where there shouldn't be. If we look at a minor or grade 1 ankle sprain on an MRI, then we would not see any tearing of ligament fibers. We may see some stretching, but the joint itself wouldn't look like it was gapping or gaping in any particular positions. For a severe or grade 3 ligament sprain, these are extremely painful, usually, although if they have torn the ligament all the way, sometimes it's not as painful, interestingly, because the nerve endings are no longer touching. But usually these are the most painful of the 3. They're going to have severe loss of function, so they will not be able to bear weight on an ankle sprain, say for instance. They will not be able to move a finger. They're going to have instability with our joint testing. When I do a joint or a ligament test on somebody with a grade 3 ankle sprain, I will choose when I want their joint to stop moving. Their joint doesn't stop on its own. So these feel very different. When I have somebody who has a ACL tear, say for instance, and I do their test, it basically feels like I could keep pulling their knee as long as I want to. They're going to have swelling, probably more severe than the grade 2. although it's not always immediate. Sometimes it doesn't come up until the next day. On an MRI, it would look like they had complete tearing of the ligament and or severe instability. And again, going back to the instability, joint stability long-term is a problem with the grade 2 moderate and grade 3 severe injuries. The ligament has been stretched and or partially torn, causing an inelastic scar. So basically, when we get this tearing in the ligament, our body doesn't, if the ligament's torn, we get a gap between the ends of the ligament now. And if our body does try to heal that space or is able to heal that space, it doesn't suck the ends of the ligament back together. You actually have to heal in the space that's now created. So if, say, for instance, we had a ligament tear and we had 1 to 2 or 2 millimeters of space between the ends of those ligaments, our body now has to heal with tissue 1 to 2 millimeters of space in between those ends to make the ligament meet again. So it will always be looser because all of a sudden it physically is longer if it does heal all the way. So it's going to be permanently loose. The person may or may not notice a difference with their movements or running, but they will have to rely on other structures, especially the muscles and tendons in the surrounding area, to make sure that that joint has some stability. So increasing their muscle tension with strength training can improve joint stability, and especially for lower extremity injuries like ankles and knees, it's very helpful to do balance exercises as well to try to improve the mechanoreceptors within the joints as well, and get the muscles and tendons to talk to each other better again. As far as a grade 3 or severe sprain, that may require surgical repair. For ankles, that's not particularly common unless a person has had so many problems that they're not able to return to normal function. For an ACL injury, if somebody has a grade 3 injury, they will more likely than not get surgery on that. Another injury that is important to talk about are contusions. Contusions are a result of a sudden blow to the body. We also call them a bruise. And they can happen to soft tissue like skin or muscles, but they can also happen to bones on occasion as well. Contusions can be deep or superficial, and then, but no matter how bad it is, you'll get some minor bleeding that will result in discoloration. So in the particular individual's case in the picture on the left-hand side of your screen, that person was struck by a ball, possibly a lacrosse ball or a baseball. You can actually see the indentation of where the ball hit them, where there is no discoloration, and all the bleeding kind of spread out from where they had gotten hit. In the other diagram, or the other picture on your slide, you can see there's different depths that the bruise can go to. The bruise could go all the way through the muscle tissue, or it may be superficial. If it goes through multiple layers of muscle or tissue, then we would consider that a deeper bruise. Once we have a bruise, we could get a hematoma or swelling from blood and lymphatic flow to the area. So I tend to think of these as juicy bruises. So this is a bruise that's going to kind of jiggle if you try to move it, versus a bruise that's just discolored. Excuse me. The bruise may be painful to the touch, they usually are, and they could have pain with active movement. So for the individual who has the thigh bruise, they're probably going to have a decreased range of motion with bending their knee especially, and they could have pain with running, walking, or jogging. As far as prevention, it's very important to use proper protection and padding. The new trend in football to wear very small pads or no pads at all for knee or thigh pads kind of drives me nuts, because we had that padding for a reason. It's to help protect against contusions like this and other types of injuries, and it's just unfortunate that the football players are moving away from that proper padding. As far as contusions go, we must be cautious and aware of more severe injuries that can happen with repeated blows. So if somebody already has a moderate to severe thigh contusion and they keep getting hit in that same spot, then you can get what's called myositis ossificans. So myo means muscle, itis is inflammation, and ossify refers to bone. So basically what happens is if you get a bruise and you keep getting a bruise in the same spot, your body kind of thinks nuts to you, you're not trying to protect me, I'll try to figure out how to protect myself, and it starts to lay down bony type tissue. So the body will lay down calcium deposits within the fibers of the soft tissue. Unfortunately, those calcium deposits can actually start to kind of tear up the muscle tissue, and it can cause some damage in and of itself. So this is a very serious injury that we want to do our best to try to avoid. We can do that by properly padding current contusions or trying to avoid getting one in the first place. If somebody has myositis ossificans, it's very important to have proper protection and rest, and that may allow for some calcium reabsorption, but if it doesn't, then the person would have to have surgery. Usually with myositis ossificans, it doesn't show up for several months after the original contusion had occurred. The quadriceps, the quads in the thigh, and the biceps in the arm are most susceptible to developing myositis ossificans, but it is possible in other muscle groups as well. Another type of injury that can occur with soft tissue is a muscle strain. So again, we strain muscles and tendons, we sprain ligaments. So a strain, sometimes also called a pull of the muscle, will be caused by a stretch, tear, or rip of a muscle or tendon. This is actually not usually caused by an overstretch of the muscle, although it could be. Most often it is caused by an uncoordinated activity between muscle groups. So we used to do a lot of static stretching prior to activity to try to avoid muscle strains, but realistically it's more about uncoordinated activity than about overstretching a particular body part, although it is possible to do that as well. The person with a muscle strain will often have pain with active muscle contraction. In this particular case, in the picture we see at the top of the screen, a person also has quite a bit of bruising or ecchymosis associated with their injury. They must have had a lot of bleeding when their injury occurred. As far as muscle grade strains, they're similar to our grades for sprains. So a grade 1 will be minor, grade 2 will be moderate, and grade 3 will be severe. In a grade 1 muscle strain, the fibers will be overstretched. The individual will be point tender and painful, but they'll have full active range of motion. So if somebody had strained their hamstring, they will still have the same amount of range of motion as they have on the other side if they go to try to stretch their hamstring. It just might be a little painful. The other thing with a strain versus overall muscle soreness or delayed onset muscle soreness that we'll talk about later, strains are tender over one spot. Like they can take an individual with a strain can take their finger and they'll say, my muscle hurts right where my finger is, or they'll show you a line with their finger. It won't be like the whole muscle hurts. That's different. As far as a moderate or grade 2 strain, we'll have many fibers of the muscle torn. Active contraction will be painful, so if they're curling their heel to their butt when they have a hamstring strain, that will hurt. And also if we were to muscle test that hamstring, they would have some decreased strength possibly, or probably. They may have a palpable depression or a divot, so we may actually be able to feel when they do an active contraction, or if they're laying on their stomach, we may actually be able to feel an indentation in their muscle that shouldn't be there. They will have possibly some swelling and bruising. This particular individual in this top slide, I would say would have either a moderate, would have what I would call a moderate to severe strain there. So that's a decent amount of swelling and bruising for a strain. As far as a grade 3 strain, that's a severe strain. So they'll have complete rupture of the muscle or tendon. They'll have severe impairment, so they will barely be able to walk, say for instance. The grade 3 strain will be very painful at first, and then the pain will diminish due to the nerves no longer being attached to each other. So usually those actually become less painful. They just won't have hardly any range of motion or any strength. In addition to our regular muscle strains, we actually can get tendon ruptures as well. So if somebody ruptures a tendon, oftentimes for the larger tendon ruptures, that will require surgery. So for the Achilles tendon, say for instance, that would require surgery. Interestingly, for a biceps tendon strain, if it's at the shoulder, usually there's no particular reason to do surgery for that. It doesn't actually help the person get more functionality back. So unless they're a high-level athlete, most of the time those bicep tendon tears aren't necessarily repaired. As far as rehabilitation for muscle strains, it's a long process for grade 2 and grade 3 strains. At least a 2 to 8 week recovery, I would say. 2 weeks is probably more for a grade 1 or a minor strain. And most of the time, the grade 2 strains take more like 4 to 6, sometimes 8. And a grade 3 I've seen take as long as 12. If the person returns to activity too soon, they may have a re-injury, and that will set them back. It's important during rehab, once the person is able, to do gentle strengthening and stretching, because we want to try to avoid the buildup of scar tissue, or at least by doing proper strengthening and stretching, we're telling the scar tissue how we want it to lay down so that it won't end up in a big clump. We're allowing it to lay down along the lines of tension as we would want it to, because that will help decrease the risk of re-injury if we're doing that proper strengthening and stretching. Some other muscle injuries that can occur with sports or with active people are muscle guarding. So I don't know if I necessarily consider this an injury, but it is something that happens after injury. So even if somebody had a sprain, the muscles in the area surrounding that sprain could guard and get tight and not want to move properly. And it's involuntary. They don't do it on purpose. It's the body's reaction to try to splint that injured body part. But if we can try to do some gentle range of motion, gentle stretching, things like that, a lot of times the person will get more function back. Muscle cramps, we've talked about a bit in our environmental lecture, but basically that's a painful involuntary contraction, most often from dehydration and an electrolyte imbalance. And that may lead to muscle or tendon injuries if the athlete or participant tries to continue exercising while they're cramping. You can get muscle strains if you continue to play on a cramp instead of trying to stop when you feel that happening. Another type of sensation people can get in their muscles is muscle soreness. So if somebody is overexerting themselves in a strenuous exercise, they can get muscle pain. Usually this happens with somebody who's doing an activity that they're not accustomed to. So if you've been lifting weights for years and years and years, and you always do the exact same lifts, and you all of a sudden add in a couple of new activities, you could get a little sore from those new activities. But most people don't really get very muscle sore from doing a known activity. Usually it's the first 2 weeks or so of a novel activity that people will experience muscle soreness. We have 2 kinds of muscle soreness. One is called acute onset muscle soreness, and this accompanies muscular fatigue. So this is a kind of muscle soreness that you could get, even if you've been lifting the same lift for a long time. This is the kind of muscle soreness we get when we're getting muscle burn in the gym when we've been lifting. This is a transient muscle pain experienced immediately after an exercise. So if you're doing bicep curls, you get that burn, it's feeling really good, and that means it's about time for you to stop. And then that goes away really quickly. Delayed onset muscle soreness is muscle soreness that occurs usually 24 to 48 hours following an activity and then gradually subsides. For some reason, as I've gotten older, it sometimes will even take longer than 48 hours. I'm not exactly sure why. But basically, there's one of the more likely reasons that this occurs is because we're getting a slight microtrauma to the muscle fibers themselves. Then the contents of the muscle fiber spill out into an area where they are not supposed to be, and that causes an inflammatory reaction. The body recognizes those cellular contents as actually being a foreign invader and causes an inflammatory response similar to if you got a bee sting or something. So it's not actually caused by lactic acid. The acute onset muscle soreness is caused by lactic acid buildup. Delayed onset muscle soreness is absolutely not. It's caused by inflammation and swelling. If somebody was getting lactic acid buildup 48 hours after a workout, they have something really wrong with their metabolic system. Our body is very, very good at clearing lactic acid because we're actually constantly making it throughout the day. So delayed onset muscle soreness is absolutely not from lactic acid buildup. As far as preventing muscle soreness, we can do that through a gradual buildup of intensity of exercise. Ideally, something along the lines of 10% every week. But if we do get delayed onset muscle soreness, we'll try to treat that with stretching and using ice within the first 48 to 72 hours. And after that, the muscle soreness should subside. Nerve injuries, thankfully, are not common in sports, but they can either be minor or severe. Main causes of nerve injuries are a compression or a tension on a nerve, and this will result in radiating pain and or muscle weakness. If this occurs in the arm from the neck being bent funny, sometimes we refer to this as a stinger or a burner. And usually with those injuries, they're transient. They don't last for very long. Some kinds of nerve injuries are acute, like a stinger or a burner, but some kinds of nerve injuries can be chronic or happen over time. So when somebody has a nerve injury, they'll have pain, and they can have sensory changes. So the types of pain you tend to get with nerve injuries are a pinching, burning. Sometimes people will say they have a sensation of tingling. So sometimes people actually don't even report pain necessarily with nerve injuries, although nerve pain is very irritating. Sometimes they'll say that they feel tingling, muscle weakness, radiating pain. Or decreased sensation in the limb. So that whole limb may just feel like it's like they can't feel it as well. If we were to touch both arms, say for instance, one arm might feel like you're not touching them as hard as the other arm. Nerve injuries can range from minor to severe, and the severe nerve injuries could be life-altering. A more minor nerve injury would be something called neuritis. This is often a chronic nerve problem caused by overuse or different kinds of forces. And this is common in the elbow, say for instance, or sometimes in the knee. And usually this is minor, but it could cause more severe problems, like decreased strength in the hand, say for instance, for the ulnar nerve in the elbow. More serious injuries for nerves would be a crushing or a severed nerve injury, and these can cause lifelong complications or implications like paresthesia or paralysis. So that would be in the case of, an extremity nerve injury, and then you could get paralysis in the foot, say for instance, if there was a nerve injury to the leg. If there's a nerve injury in the central spinal cord, or in the central nervous system or the spinal cord, then you can get paraplegia or quadriplegia, possibly. The healing process with nerves is very slow. It could be 3 or more months. Nerves just don't heal very quickly. The optimal environment for nerve healing is critical, and if we can cool the area well, sometimes the nerves will not get as much damage. So with people who've had spinal cord injuries, there's been a lot of research into trying to actually lower the whole body temperature to try to stop the inflammation and swelling that occurs in the spinal cord to try to preserve function for that person. And for some people, that's really helpful. As far as central nervous system, or CNS, versus peripheral nervous system, or PNS, the central nervous system takes longer to heal than peripheral nerves. So peripheral nerves would be nerves in the arms or legs. Those nerves will heal faster than the spinal cord would heal. We've talked about a lot of acute injuries already in this chapter, but I would also like to go over chronic, or quote-unquote overuse injuries as well. As far as chronic injuries go, if somebody's had a chronic injury for a long time, it can take longer to heal. Acute injuries, a lot of times we have a timeline that we kind of go by that's fairly accurate. With chronic injuries, that can be a little harder because it depends on how long they've been injured. The other thing that we will talk about is there's a difference between acute inflammation and chronic inflammation. Inflammation in and of itself is really important in healing. It's an essential part of the healing process, actually. And inflammation must occur following tissue damage to initiate healing. So when we're talking about inflammation, what that really means is what happens right after an injury. So the pain, redness, swelling, loss of function, and warmth that occurs after an acute injury is inflammation. But if the source of that irritation is not removed, then the inflammatory process can become chronic. So with acute inflammation, we tend to think of it as being, or I tend to think of it as being red hot and angry, right? So inflammation, flame, like fire. But chronic inflammation is slightly different. We'll talk about that on later slides. So we have two different injuries that can affect the tendon as far as irritation of the tendon. So tendinitis is what people tend to call both tendinitis and tendinosis, but they actually are different. Tendinitis is the most common overuse problem in sports. Usually we have a gradual onset, so it's not usually, the person won't say, like, I know exactly what happened when my tendinitis started. Usually it's over time. They say, oh, my Achilles started to hurt when I was running, and then it just gradually got worse and worse. The person will get tenderness due to repeated trauma and or degenerative changes. The most obvious signs are swelling and pain. So if somebody was complaining of pain in their, or if they were complaining of pain in their Achilles, if we notice that their Achilles was swollen, they were having pain, they may also get some creaking or crunching or like a type of feeling in their Achilles when they're running or walking. That would point us towards some type of tendinitis or tendon injury. Sometimes you might see a doctor write down that somebody has a tendinopathy. That's a really general term, so we don't use it very often because it's not particularly specific. But basically, tendinopathy just means there's something wrong with the tendon. Tendinitis specifically means an acute inflammation of the tendon. So acute inflammation means that that's been happening for a short period of time. You cannot have tendinitis for 2 years because it may have been tendinitis for 2 weeks, but then it turned into tendinosis after a few weeks or maybe a month. Tendinosis is a chronic tendon injury, so it's something that's happened over time that is continuing, but it may have started as tendinitis and then moved into tendinosis. For tendinitis, that's our acute inflammation, so red hot, angry. Our treatment for tendinitis specifically is PRICE, so protection, rest, ice, compression, and elevation. And we don't always need, compression and elevation if they're not super swollen, but just those general ideas of being nice to it and giving the body part a lot of relative rest and icing a lot. Basically, we want to avoid any activities that aggravate that condition. So if somebody has tendinitis in their Achilles tendon, if they're having a lot of pain with walking, then we might put them on crutches, but most of the time people will be okay as long as they're just not running on it. With tendinosis, that's the chronic tendon injury. What happens with chronic irritation or inflammation is that we actually go from a red hot angry phase to where the body starts to decrease the blood flow to the area, and it starts to not try to continue the healing process, And so the healing process kind of stalls, and the injured area becomes more white, cold, bloodless. So the treatment for that is going to be really different because we're not in the fiery part of the inflammation, we're in a more cold part of the inflammation. So for tendinosis, our treatment will be stretching and massage, maybe combined with stretching. Then we may also do some specific, possibly eccentric exercises that could replicate painful activities. So for an Achilles tendon, we might do calf raises, say for instance, for tendinosis. And it may be a little uncomfortable, but for tendinitis, we would try to avoid that. So there's very different treatments for these two different conditions. So say for that Achilles tendinitis, we may do eccentric calf raises. So we would go up on both feet into a calf raise. We would lift up the uninjured side, and we would slowly lower down on the injured side to try to almost kick the injured area back into a slight irritation so that we can start to begin the healing process again. Tenosynovitis is basically a close cousin to tendinitis. Tenosynovitis just means an inflammation of the synovial sheath surrounding the tendon. So the covering of the tendon gets irritated. Honestly, most of you guys probably wouldn't really be able to tell the difference so much between tenosynovitis and tendinitis, and the treatment will be very similar. So it's not completely necessary to know the difference, but they are different. In an acute case of tenosynovitis, we'll get a rapid onset crepitus. So we call this snowball crepitus actually because it almost sounds like when you walk in snow, that kind of sounds. So more of a like squeaky type of crepitus as if you were stepping into snow. And they'll have diffuse swelling. So usually this is kind of a juicy swelling compared to tendinitis, which is usually more of a softer swelling. For a chronic case of tenosynovitis, we can actually get a thickening of the tendon with pain and crepitus. So if we were to look at the tendon side by side, sometimes the tendon will even look twice as big as the other one. These are common. The tenosynovitis is common in the Achilles and flexor tendons of the fingers. Again, our treatment is similar to that of tendinitis. We also might use some NSAIDs, so non-steroidal anti-inflammatories, like Advil, Motrin, Aleve. Those kinds of things may also help. Another overuse injury that we will discuss is called bursitis. Now, bursitis is often from overuse. It can also be from an acute trauma as well. But a bursa is a small fluid-filled sac that our body just naturally develops in an area of high friction. So everybody has bursa in their knee. We have bursa in our shoulders. But there are areas where there would be friction of tendons rubbing on bone or tendons rubbing on each other or bone rubbing on bone. Our bodies just create these fluid-filled sacs. So in this picture on the slide, we see a picture of bursitis in the left knee. That is a moderate to severe amount of swelling for a bursa, and sometimes there's an old term called water on the knee that you may have heard of before, and that's also referring to bursitis. An acute bursitis will be caused by a sudden irritation, so often from landing from a fall, or maybe the person went and did a novel activity like running farther than they're used to, and they could cause some bursitis that way, or they were throwing too much with their shoulder and it caused some bursitis. Chronic bursitis is caused more from overuse, so overuse over time. So chronic bursitis in the knee would probably be caused or be secondary to somebody also having tendinitis in the knee, and they're both getting irritated together. Chronic bursitis in the shoulder is really common in overhead athletes like throwers, pitchers, volleyball players, swimmers. But basically what happens with bursitis is that the little water balloon or the little fluid-filled sac called the bursa gets irritated, and for whatever reason that irritation causes it to produce more fluid inside that fluid-filled sac. So as that fluid increases, the water balloon becomes bigger. and that water balloon becoming bigger in a confined space will increase the pressure both on the bursa and on the surrounding tissues. The unfortunate thing about that is if there's not a lot of space for the bursa to swell, that it actually creates more inflammation. So it's kind of a unfortunate cycle that some people fall into. Our signs and symptoms for bursitis will be swelling. We may not always be able to see the swelling, like if it's the bursa in the shoulder, it's under a bone, so we may not be able to see that, but in the knee it's very clear. In the elbow it's very clear. The person will have pain and some loss of function, so it might be harder for this individual in the photo to bend their knee. It may feel awkward to run. They won't want to fall on it for sure. Our treatments for this would be price, and although with the tendinitis, the compression and elevation isn't really as important, with a very swollen bursitis like this in the knee, compression and elevation actually would be pretty helpful to get rid of some of that swelling. We're definitely going to want to ice the bursitis and protect it, try not to irritate it any further. We're going to want to take those NSAIDs like Motrin or Aleve. Our three most commonly irritated bursa in our body are the subacromial bursa in the shoulder, the olecranon bursa in the elbow, and the prepatellar bursa in the knee. Another type of overuse condition that people can get that is very common is called a myofascial trigger point. So this is basically a really bad knot that will develop in a muscle due to some kind of mechanical stress. So this can happen from an acute strain, but I've seen it most often from sustained poor posture, so static postural positions, producing a constant tension on the muscle. So I often see this, especially in the physical therapy clinic, with people who have a very forward head, maybe they're on their computer a lot or they text a lot, their shoulders are forward rounded, and then their upper traps get these huge trigger points that cause them a lot of pain in their neck or down their back or down their shoulders. And if probably for most of you in class, if you were to reach back and just massage your shoulders, you'd probably feel a lot of tension, and you may even find one particularly sensitive knot or one really big knot in your shoulders. Most likely that's a trigger point. These do most often occur in the neck, upper and lower back. Some signs and symptoms for this would be pain with palpation and a specific pattern of referred pain that could also limit motion. So I've had them in my upper trap that actually do run down past my shoulder about halfway down my arm. And if I push on it, I can recreate that pain. So sometimes if we get referred pain down the arm, it's actually from a neck injury. That could be common. But if I can recreate that pain by pushing on the knot and then having that referred pain go down the arm, then I know that's most likely from a trigger point. The pain may increase with active and passive range of motion with the involved muscle. So when the person is actually trying to use that muscle, their pain could increase. These are pretty nasty and more common than most people realize. And the good news, nice news, is that the treatment is fairly simple and it's usually not a permanent condition. Our treatments for this would be stretching, self-massage. I often do self-massage for the upper traps with a lacrosse ball or a tennis ball. Foam rollers are really great for this. There are lots of other specialized massage tools, or even, getting a massage wouldn't be a bad idea as well. And the person can ice or heat as needed. With most acute injuries, we want to be really careful to only ice. This is not an acute injury though, so if the person wants to try heat, that's totally fine. Everybody has different preferences when it comes to ice or heat, and unless it's an acute injury, I could go either way. Osteoarthritis is a very common condition, especially in older adults. So for those of you who will be working with adults over the age of 40, you will be dealing with people having osteoarthritis. It's very normal. It's just a normal part of aging. I think I already have it in my hands from years of using my hands so much, and I am on the younger side of that age range. But osteoarthritis is defined as the wearing away of the hyaline cartilage as a result of normal use. So the hyaline cartilage is, again, that shiny cartilage that covers the end of the bone. This can happen more so or earlier for people who have repeated trauma as far as changes in joint mechanics, because that can lead to joint degeneration. So people who have, like an ACL tear and then they end up having surgery are more likely to get osteoarthritis earlier in that knee, say for instance, than the other one, because they've had a trauma and then the joint mechanics are going to be different after surgery. Also, this can happen as a result of a direct blow, pressure from carrying heavy loads over time, or activities such as running. Basically people who are active are more likely to get osteoarthritis. However, people who stay more active are more likely to have less pain from their osteoarthritis. So being active is kind of a double-edged sword when it comes to arthritis. Osteoarthritis commonly affects weight-bearing joints like the knees, possibly ankles, very often spine, cervical spine and lumbar spine. We have a table that we use to show patients in the physical therapy clinic, and degenerative changes in the spine are extremely common after the age of 40, really. Even for patients in their 60s, it's more common to have degenerative changes like arthritis in the spine than it is to not have those when we're looking at an MRI or an X-ray. Our symptoms of osteoarthritis are pain, stiffness, especially stiffness in the morning, local tenderness. So it's not usually like one spot that the person can put their finger on that hurts. It's just kind of a general area, that's enclosed in one space. So maybe like the medial side of the knee, but it won't be like one spot they can put their finger on. They could have creaking or grating. The grating is relatively common, and it almost sounds like, sometimes it sounds a little squeaky, but it'll sound like a kind of sound, and sometimes you can hear it, sometimes you just feel it. And the person will have generalized joint pain. Our treatment is low impact exercise. We often tell our patients in the physical therapy clinic, motion is lotion when it comes to an arthritic joint. So the more we use that joint in a safe manner, then the joint should feel better. Also, using heat could be helpful, or NSAIDs for chronic or for acute flare-ups would be fine. We don't want to chronically use NSAIDs like Advil or Aleve because of the risk of side effects, though. So we've gone over many different types of injuries that people can get. Now we're going to go over the importance of the healing process following an injury. It is really important to possess an understanding of the sequence and time frame for phases of healing so that we don't expect too much or too little from someone who has been injured. We shouldn't expect somebody to be able to perform normally when they're in an inflammatory stage of healing. They're just not going to be able to do that most likely. The other thing that's important to understand is that the interruption of the healing process will delay return to full activity. If we re-aggravate an injury, it's going to take longer for the person to get better and to get back to their full potential. It's super important for us to create an optimal healing environment when it comes to allowing an injury to heal, because there's not a lot we can do to really help a person heal faster, but there's a lot we can do to actually make the healing process slower and make it stall or go back to the start. On this slide, we have a graphic of the 3 phases of healing. So our first phase of healing happens from the time of the injury to a couple days later, so maybe up to a week later, and that's called our inflammatory response phase. It's really the strongest in the first 72 hours, so that's why we're trying to use ice or price the most during those first 72 hours, because we're trying to put some cooling on the flame of that inflammatory response. Our next phase of healing is called the fibroblastic repair phase, and that's going to be our mid phase of healing. It'll start a few days after the injury, and it can go up to 6 weeks after the injury. And this is a somewhat fragile state that it's really easy to get stalled in this phase of healing. And then we have to try to kick ourselves back into the inflammatory response phase if possible. Maturation and remodeling is the final phase of healing, and that starts maybe about 3 weeks to a month into the healing process, and it can go on for years. So if somebody has had an ACL reconstruction, say for instance, their graft is not going to be at its full strength until 2 years after surgery. That's just how long it takes the body to completely repair something. So when we talk about the 3 different stages of healing, in my mind, it makes sense to use a visual of somebody having a brick wall in front of their home, and somebody comes and just drives their car straight through the brick wall and causes an injury to the wall, right? So maybe a drunk driver drove their car directly into this person's wall. The homeowner comes out and they sees what happened, and they're just livid. They're raging mad. They're so angry. They're red. They're red hot and angry, and they're in that inflammatory response phase. So the damage happened, and then they're really red hot and angry and super worked up. So this is something that happens. That inflammatory response phase happens immediately following an injury. It is very important to have this, otherwise we will not have other phases of healing. And this normally lasts 2 to 4 days. Now, just because this is important for it to occur doesn't mean we want to let the inflammatory response phase go off the deep end. We're not going to let the homeowner go and shoot the drunk driver with a gun, right? We want to try to be civilized and keep the inflammatory response phase to a minimum as much as we can, and that's why we use price during this time. What will happen as we're going through this phase is that the white blood cells will come in. We'll get phagocytosis, where the white blood cells will help to clean up the injured area. We'll have other chemicals released to help facilitate healing, and we'll start that healing process. So we have that red hot angry phase, and then we start to plan, how are we going to fix this? Our symptoms with this are going to be redness, swelling, warmth, tenderness, and loss of function. So when that drunk driver drove through our wall, it has a loss of function. It doesn't work anymore. It doesn't work as a wall anymore because there's a big hole in it. And the homeowner is going to be really super angry about that whole thing. So that's our red hot angry phase. Our next phase of the of the healing process is the fibroblastic repair phase. So if we're using our example of the drunk driver driving through a brick wall on somebody's property, this is going to be where we have our proliferation and regeneration occurring. So this would be where the homeowner goes to Home Depot and gets more bricks and more mortar and some mortar to fix the wall. So we're going to get that scar formation beginning. We're going to gather our materials, bring all those materials to the site of the injury, and dump them. That's what the body does too. Our body brings a bunch of collagen fibers to the area and just plops it down in a big old pile right next to the injury, just like we would do with our bricks. This can occur within the initial hours of the injury, so again about 72 hours-ish, and continues up to about 4 to 6 weeks. So if the homeowner brought his bricks to the wall and just dumped them in a pile, the wall's still not going to function really well. So ideally, that person will start to slowly add more bricks to the wall. They may not finish it all in one day, but they'll slowly start to add those bricks, or the body will add those collagen fibers to the injured area and start to slowly build up that scar formation. The homeowner will start to slowly rebuild up the wall. After the signs and symptoms of the inflammatory phase subside, so that pain, red hotness subsides, the person will still have some pain with motion. The homeowner's still worked up about the wall a little bit because he's having to fix it. He doesn't want to have to deal with this business. But as the scar develops, the pain and tenderness will decrease. As the wall is fixed, the homeowner will become less angry. So the scar developing and becoming more like normal tissue should cause the injury to hurt less. Just like the injured body part, or the injured tissue in the body, that brick wall, the bricks in the wall, will look different for a long time. it will look like different skin, or different. It'll appear to be different. You'll be able to tell there was damage at some point that was fixed. Just like if you skin your knee, even after the scab falls off, the skin looks different for a long time. You're still in that fibroblastic repair phase, but as you go through the maturation remodeling phase, the skin becomes more like the other tissue surrounding it. The brick wall over time will become weathered and look similar to the rest of the wall. It is easy to get stuck in this phase if you try to return to activity too soon. So, say for instance the homeowner had to go back to work on Monday and he didn't finish the wall. It's going to have to sit there for a week. Maybe he gets busy. Maybe he has stuff going on with his kids, and all of a sudden he can't fix the wall, and then it's half built. Kind of the same here with the fibroblastic repair phase. If you try to keep doing stuff on the injured body part, it sometimes won't heal itself. It'll just kind of stop trying to fix itself. And if that happens, and sometimes we have to try, if it's been over time and it's not getting better, we'll have to try to irritate the area just a little bit to kick it all the way back into the inflammatory response phase. So our last phase of healing here is the maturation remodeling phase. This is a long-term process. It starts about a month in or so, and then it will last for years. During this time, we will hopefully be getting an alignment of the scar tissue with the forces acting on the tissue. So if somebody has a muscle strain and the body has brought all these collagen fibers to the damaged area and then just dumped them, if we're not doing appropriate strengthening and stretching and activities like that, that clump of collagen fibers will just sit there. It won't become more like normal tissue because we're not pulling on it in a way that will get it to be more like the normal tissue. We're not telling it how we want it to act. So ideally, if we're having a gentle pulling on the scar tissue, not so much that it tears, but enough for it to know where to lay down, it will realign parallel to the lines of that tension. The tissue will gradually resume a normal appearance and function over time, but it usually won't be as strong. So just like if we've had a bad scar on our skin, you'll notice it's sometimes easier if we bump that skin to tear it open versus the skin next door to it. The scar just isn't as strong until years later. After about, again, 3 or 4 weeks, we get a firm, strong, contracted, non-vascular scar. And then over time, we'll start to get more blood vessels populating the area, and the scar will start to look more like normal tissue or act more like normal tissue. And again, that maturation may take several years to be totally complete. So this is a graphic just showing you some of what we had talked about. Under the letter A on that top portion of tissue, that's our inflammatory response phase, where we start to get, we're getting bleeding, and then a blood clot forms, and you get the phagocytic cells to come clean up the damaged cells. Next, we'd have the fibroblastic repair phase. That's the bottom left-hand picture. The fibroblasts will lay down those collagen fibers, forming a scar. So you can kind of see underneath the open wound how you have just a clump of fibers hanging out down there. They're not real organized. And then on the tissue labeled C, on the right-hand side of the bottom, we have a picture of our maturation remodeling phase, where scar tissue has remodeled and starting to realign along the lines of stress and strain. So we're not seeing that big old clump and mess of collagen fibers. We're starting to see what looks more like a mature scar, more like the normal tissue surrounding it. And that is all for our healing process.